Okay, we're at the top of the hour, so first of all, thank you everyone for joining. My name is Grace Kavanaugh. I'm the Education Chair for the International SIG. Thank you so much for joining today's member webinar. Any GC can be an international GC, advancing and supporting global genetic counseling from the US. We encourage you to ask questions throughout the presentation. As a courtesy to our presenter, all attendees have been muted. Please utilize the Zoom Q&A box for your questions that you may have throughout the presentation. The chat function is also available for discussion throughout the talk. Questions will be read aloud during the last 10 minutes of the webinar. We know that many US-based genetic counselors have an interest in supporting genetic services around the world, but may not know where to begin. In this webinar, we will hear from speakers who are making an international impact while still working and living in the US. Our speakers will discuss their work in 3 key areas: professional societies, allied healthcare professionals, and training programs. We hope this inspires you to be part of the work expanding global genetics care. Today's learning objectives are: 1, summarize the process of forming a genetic counseling professional society outside the United States. 2, apply transferable genetic counseling skills to train allied healthcare professionals globally. And 3, identify strategies to create and support genetic counseling training programs outside the United States. Today, we are joined by 3 wonderful speakers. I'll introduce each of them now. Our first speaker is Daniela Diaz Caro. Daniela is a research genetic counselor at Columbia University Irving Medical Center. She graduated with her master's in genetic counseling from Stanford University and is one of 3 founding members of the Latin American Professional Society of Genetic Counseling. Our second speaker is Michelle Jacobs. Michelle works in a split clinical and research role as a cancer genetic counselor at the University of Michigan in Ann Arbor. Her interests include cascade testing, alternative service delivery models, and paired tumor germline testing. Michelle loves to travel and has a corresponding interest in global health. Michelle has pre-recorded her talk, but will be present for the Q&A session at the end of the webinar for live questions. Our third speaker is Aisha Furkan. Aisha works as an oncology genetic counselor at Natera. She has over 5 years experience working in rural oncology clinics. She has a master in genetic counseling from Stanislaus State University and is certified by the American Board of Genetic Counselors. After all 3 of our speakers present, we will have time for the Q&A. And with that, I'll hand it over to our first speaker, Daniela.
Thank you so much for introducing me, Grace. It's an honor to be speaking to all you today about the creation of the Latin American Professional Society for Genetic Counseling, also known as SPLAGen for its Spanish abbreviation. To begin, I'd like to state that I have no conflicts of interest to disclose. And the learning objectives for this presentation are the following. I will define the current status of genetic counseling profession in Latin America. I will explain the reasons and process for establishing a professional organization. I will go over our mission, our goals, and the current organizational structure that we have. And lastly, I'll give examples of how genetic counselors in the US can help promote genetic counseling services in Latin America. So for this presentation, I am defining Latin America as nations in the Americas and Caribbean whose residents predominantly speak Spanish and Portuguese. This includes 33 countries and 1 US territory, which is Puerto Rico. In Latin America, genetic counseling is not a recognized profession. It's only recognized in Cuba. It's the only country in Latin America that it is recognized. And Cuba is also one of the 2 countries in Latin America, the other being Brazil, that have a genetic counseling master's program. In the Cuban program, the majority of trainees are physicians in specialties other than genetics, or they are healthcare workers such as nurses or psychologists. In most other countries in Latin America, the practice of genetic counseling is primarily performed by geneticists, And in a few instances, there are other healthcare professionals practicing genetic counseling who have attained advanced training through certificate programs. So taking all of this into account, the major challenges to providing genetic counseling in Latin America are the lack of access to professionals trained in genetic counseling and the limited educational opportunities for genetic counseling. So having this background knowledge, the idea of a professional society really originated after a series of conversations amongst members of the MGPN Latinx community. We had conversations about the lack of contact we had with genetic providers in Latin America. And in these conversations, many individuals described the challenges they faced in clinic, not knowing how or to whom refer family members of patients at risk of a genetic condition that lived in Latin America. So for this, a working group was organized to resolve this issue. And as a group, we began to reach out to genetic counselors and geneticists in Latin America in order to gather their contact information and build a directory. There was one conversation in particular with a genetic counselor from Chile, Sonia Margarit, that was really impactful for us in the development of this society. Sonia shared with us the difficulty she had being a genetic counselor in Chile, where there's a lack of awareness of genetic counseling practices. There are there's lack of support for professionals practicing genetic counseling. And also she described the challenges that she had getting people to see the value of genetic counseling. She expressed that it would be helpful to have a group that promotes genetic counseling in Latin America. This really motivated us to start a supplemental project to investigate whether this was a common experience with others practicing genetic counseling in Latin America. So to connect with the broader Latin American community on this perspective, we created and distributed a survey. The goals of the survey were to first gather contact information of Spanish and Portuguese providers practicing genetic counseling in Latin America, and this was done to create our directory. The other goal was to gauge if there was an interest in establishing a professional society for genetic counseling, and if so, to define its goals. We sent this survey through various means, such as emails to medical genetic societies and our own professional contacts that we had in Latin America, as well as sharing it through social media. And we received many responses from providers, primarily geneticists living in Latin America, who were interested in professional support. So here are some key words that were mentioned frequently to give you a quick overview of the topics of interest among those surveyed. Professional development and education were commonly mentioned, as well as networking and community building. More concretely, we organized the responses in 3 priority areas. The first of these priorities was barriers to access, which includes the following issues. Respondents shared how there's minimal access to genetic counseling outside of major cities. There's limited access to genetic counseling testing, largely due to the lack of availability of laboratory testing services and the consequently high cost of providing genetics care. The second stated priority was barriers to professional recognition. Respondents shared that there's few educational opportunities. There weren't that many jobs for genetic counselors and geneticists as well. And there's no official way of accreditation or regulatory system defining genetic counseling as a profession and determining who may provide genetic counseling services in Latin America. The other topic mentioned was the lack of educational and professional resources. Respondents reported an interest in obtaining continuing education in genetic counseling, creating training programs, as well as their willingness to engage in networking to enable partnerships that provide support for patient cases, clinical resources, and larger research activities. So all of these responses motivated the development of the Genetic Counseling Professional Society in Latin America. So having all these responses in mind, we thought that it would be beneficial to have some form of structure to guide and motivate how we address the needs and interests of the genetic counseling profession in Latin America. So to begin, we selected a name, which I've shared, the Latin American Professional Society of Genetic Counseling, also known as La Sociedad Profesional Latinoamericana de Asesoramiento Genético, or SPLAGen, and we established our mission. The Society's mission is to promote awareness and access to genetic counseling services in Latin America. And our goals as a society, we intend to achieve this mission by promoting the initiatives aimed at increasing genetic counseling education opportunities, advocating for public policies that will improve access to genetic counseling services, fostering research collaborations, as well as executing research in genetic counseling in Latin America. And lastly, we hope to establish a membership or a network of support for genetic counseling, for the genetic counseling community in Latin America. And so after having this clear idea of our mission and goals, we drafted our bylaws. And in it, we outlined who is eligible for membership, which in addition to genetic counselors includes healthcare workers who practice genetic counseling in Latin America. We also drafted our descriptions of the responsibilities for those in our leadership positions, and we created a website where we use to showcase our work. And currently, this is what our organization looks like, or the leadership position look like as is currently laid out. Our leadership is made up of our board of directors and our committee chairs. And I do want to point to the other two individuals who founded SPLAGen, one being Lori Simone and Amanda De Leon. And we established our committees based on our goals. So we have an educational committee, a members committee, and a public policy and access committee. And we're still looking for volunteers specifically to fill the chair position for the research and ethics committee. Our first meeting as a group was this past August, and I'm grateful for all the individuals on this slide who have volunteered their time to help achieve the mission of SPLAGen. And at this moment, our current focus is the following. We like to first obtain our nonprofit status, which is necessary for accepting and distributing funds. We also intend to continue extending our membership and compiling the contact information of genetic counseling professions in Latin America in order to enhance our directory and foster future collaborations. And lastly, we're in the process of establishing our overarching strategic plan and the objectives of each committee. So if anyone is interested in our mission, you can learn more about our upcoming meetings and our projects by subscribing to our newsletter. And you can do so by going to this site or scanning this QR code. And genetic counseling students, as well as professionals who practice genetic counseling, are welcome to join. I should state that at this time, the newsletter is only available in Spanish and Portuguese. We're also looking for volunteers who can help us grow our partnerships in Latin America, and we're looking for people who can advise us on how to best secure revenue to fund our projects and general guidance for our public policy, research, and educational efforts. If you're interested in volunteering or collaborating with us in any way, we ask that you please reach out to us at our email, which is info@splagen.org. And we are also, if you're interested in just following us on social media, you can hear updates from our projects by just following us on Facebook, Instagram, LinkedIn, or Twitter. And I like to end by stating that the Spanish and Portuguese provider directory, which was the project that really began the conversations for SPLAGen, is finally completed. And I wanted to share with you today that this work is now published on our website and it's accessible for anyone to use. This directory was completed thanks to a grant from the Texas Genetic Counseling Society, and with the help of the individuals shown on this slide. And finally, I'd like to express my gratitude to everyone who has contributed to the SPLAGen's current state. We appreciate those who contributed their knowledge and time to building a SPLAGen, to those who served as role models for us by carrying out similar work in other parts of the world. And thank you to all those who took the time to complete our survey, and of course to the International SIG and NSGC for giving us the opportunity to share our work with you all today. So thank you.
And I'm a genetic counselor at the University. Hi, everyone. I'm Michelle Jacobs, and I'm a genetic counselor at the University of Michigan Cancer Genetics Clinic. Today, I'll be talking about my experience planning and leading the first training program in genetic counseling for nurses in Ethiopia. I have no conflicts of interest to disclose. This work was funded by CERT, which is a University of Michigan program that supports its providers in implementing various initiatives related to reproductive health in Ethiopia. Today, I'll provide an overview of the landscape of genetics and genetic counseling in Ethiopia, talk briefly about some of our early work there that informed the content and logistics of the training program, then focus on our experience and outcomes from teaching a brief course about genetic conditions and genetic counseling to nurses. There are no geneticists or genetic counselors practicing in Ethiopia, and providers there generally have very limited training and experience in genetic conditions. The hospital we work with, St. Paul's, is the second largest hospital in the country and is located in the capital city, Addis Ababa. There's only one lab in the country that provides genetic testing, and this testing is limited to MLPA for the detection of aneuploidies and some microdeletions and microduplications. I want to briefly review the work we completed before implementing this training program. As first steps, our group completed a needs assessment with physicians at St. Paul's to learn about their existing knowledge and resources surrounding genetics. We also launched a family history collection app in the prenatal, pediatric, and NICU wings to determine the prevalence of common conditions for which genetic evaluation is recommended, such as trisomy 21 and heart defects. That work found that about 4% had an indication where genetic counseling was recommended. A survey of pregnant patients was also completed and showed broad interest in prenatal testing and interest in potential termination of pregnancy for certain congenital anomalies or genetic diseases. I came in after this work had been completed, with my first trip to Ethiopia being in May of 2018. By this time, we'd established that there was interest from St. Paul's Hospital leadership in expanding the genetics knowledge of its providers. We spent that trip trying to figure out some key logistics, such as who would deliver genetic counseling services, what conditions were most important to include in the curriculum, and started thinking about logistics such as potential location of a genetic counselor clinic. We also conducted semi-structured interviews with several nurses. During this same trip, we conducted a survey of patients about their knowledge and attitudes towards genetic counseling. This was a survey previously used in North American populations. A takeaway from this survey that was encouraging in us moving forward with the training was that after hearing a brief description of genetic counseling, patients generally held positive views towards it. Then I'm going to talk about these last two time points in a lot more detail. The information I'm presenting today was previously published by our group, and I need to give credit to everyone listed here for their work on this initiative, and particularly Shane at NAFU, Delayu, and Abate, as they were all involved in those earlier projects I mentioned before I joined the group in this work. To go back to those interviews with nurses I mentioned, the focus for those was on the nurse's role in patient care and the dynamics of patient interactions. A major takeaway from speaking with providers at St. Paul's is that the concept of facilitated decision-making is relatively unheard of in Ethiopia. Cultural norms dictate that a family member may make decisions on behalf of a patient, or medical decisions are often made based on provider recommendations, particularly in cases where there's limited medical literacy in patients and their families. We also worked with several physicians at St. Paul's to get input on the congenital anomalies and genetic conditions they see most commonly, to attempt to prioritize certain medical knowledge in the curriculum, the goal being that providers receiving this training would have opportunities to use it. Our hope was that there would be nurses in the first cohort of trainees who would be able to act as trainers for the second group, so that this training program could be sustained with a train the trainer model, even when members of the US-based part of the group were not present. The curriculum we developed had components focusing on medical knowledge, as well as lectures containing genetic counseling content. A team of 3 genetic counselors, including one with experience in international course development and delivery, and 1 physician from the University of Michigan, did the bulk of course development using the input and feedback from the physicians at St. Paul's. We also used the recommendations of core competencies in genetics essential for all health professionals, which were put forth by the Core Competency Working Group of the National Coalition for Health Professional Education in Genetics in 2001 for guidance. Course evaluations were also developed, which included evaluations for each individual lecture, as well as for the overall course. We also devised a knowledge assessment, which was given to nurses on the first day before receiving any training, then the same assessment was given on the last day after training was complete. This shows the core competencies that were covered in the 30-question knowledge assessment. These questions were mapped back to the core competencies from that resource I mentioned, with the goal being that we'd be able to measure improvement in different areas. Some of these questions covered multiple competencies. The first cohort to undergo training consisted of 7 nurses, 3 from OB and 3 from peds. This training was delivered over 3 half days in October of 2018 and covered the topics listed here. The amount of time allotted for this training was based on how much time St. Paul's gave the nurses away from their clinical duties. Training included 9 lectures, 9 problem sets, 3 small group discussions, and a role-playing exercise. It was held in a conference room at the hospital. And medical training in Ethiopia is delivered in English. So this training was delivered in English as well. And we had the assistance of an Ethiopian physician who would translate as needed. I'm going to review the outcomes from cohort 1 briefly, just to share how they informed our plans for the next cohort. This shows the different competencies for cohort 1. The pre-training scores on the knowledge assessment are in blue, and the post-training scores are in orange. There were no significant differences in knowledge in the pre and post-training assessments, although knowledge overall was increased. A lot of time was spent on psychosocial concepts during that first cohort, and feedback from the trainees indicated that these topics were confusing and difficult for them to learn. This shows the feedback from the full course evaluation, which was collected at the end of training. The one point I want to make here is the last question we asked about workshop length, with 1 being much too short and 5 being much too long. And on average, participants felt the training was too short. Now I want to discuss changes we made for the second cohort of nurses who were trained in July of 2019. Significant curriculum modifications were made following our experiences with the training of cohort 1. The volume of delivered content combined with limited previous exposure to medical genetics resulted in difficulties with content retention, as seen by the fact that no statistically significant improvements were noted on the post-assessment for cohort 1. Given the limited time available to deliver this training, we decided to increase the focus on medical knowledge content. Again, given that feedback from the first cohort that genetic counseling principles were difficult to grasp. 15 nurses were trained in cohort 2, 13 from OB, 2 from peds, and this training was held offsite at a hotel conference room. The increased time available for medical knowledge content allowed for additional problem-based examples to be used. So in addition to role plays, there were 57 supplemental problem-based examples that were used in cohort 2, as opposed to the 9 problem sets that were covered with cohort 1. With these modifications, there were significant improvements, or statistically significant improvements, in medical knowledge retention in cohort 2. To identify which of these components were most improved, competency mapping revealed that the medical knowledge specific competency scores were significantly improved, especially when compared to genetic counseling specific competencies, with the stars on there representing differences that were statistically significant. Even with these significant changes to the curriculum, we were able to use the same knowledge assessment with both cohorts, which allowed for direct comparison. Anecdotally, trainers for cohort 2 also noted that during the training, there was an obvious improvement in trainee comprehension of the medical knowledge compared to their experiences with cohort 1. To review this chart now in detail, overall, the trainees were very satisfied with the course. Trainees thought the lectures, problem sets, and role-playing exercises were useful and effective, felt prepared to use the knowledge and skills learned, and would recommend the training to others. This was true across both cohorts, although scores were slightly higher in the second group. Cohort 2, on average, also felt that the workshop length was closer to just right, as opposed to cohort 1, which had noted it was too short. Participants in both groups were provided with a few copies each of a genetic counselor checklist, which lists some key components of a genetic counseling session. The hope here was that the nurses could use these for their first few sessions to help remember different things to discuss with patients. This is a table from our publication that highlights logistical, cultural, financial, and system-specific considerations when implementing similar training programs internationally. Some of these barriers were anticipated, while others were unanticipated. I recognize this may be difficult to read, and rather than go through each item, I want to mention a few specific barriers we encountered and how we dealt with them. This table is available in our publication if you want to reference it later. So one thing that I did not anticipate when starting this work was the difficulty in communicating with providers in Ethiopia while we were in the US. St. Paul's does not have reliable internet, so the small number of virtual meetings we scheduled were not always able to be completed as planned. The majority of our collaboration with the St. Paul's team happened while we were physically present in Ethiopia, so it was really important that we get as much done as possible during these trips. There are also limited resources at the hospital. For example, any printed materials for trainees needed to be printed in advance and brought with us from the US. There was also an expectation from the nurses that they would receive a per diem for attending training, which differs from typical expectations for attendees of training in the US and was unanticipated by the trainers. Thankfully, we were in a position where we were able to meet these expectations and then request reimbursement from the funder after returning to the US. Specific to St. Paul's, we learned after training cohort 1 that it is normal for nurses to rotate through different areas, and several of the nurses who received this training were then rotated off of pediatrics or obstetrics onto clinical rotations where the training was less applicable. Prior to training cohort 2, St. Paul's agreed to select nurses for training who would be on pediatrics or obstetrics rotations for the foreseeable future. As I mentioned earlier, our intent was for our workshops to follow a train the trainer model. But when the team arrived to train cohort 2, we had planned to spend time reviewing the course content with two nurses from cohort 1 and have them lead training for cohort 2. Then upon arrival, it was requested that the original US-based trainers lead the training. 2 trainees from cohort 1 did assist as trainers and delivered some of the content for cohort 2, but we are uncertain of the ability of this to continue for future groups. The reasons for this are multifactorial. They include many of the barriers outlined in this table, but also considering that this is an all new and complex subject for the trainees. There are uncertainties regarding the minimal level of competency needed to function as an effective trainer. And we expect additional work would be needed to enable these nurses to feel comfortable acting as future trainers. Finally, we were unable to maintain contact with the nurses once we were back in the US. So we're unsure of the utility of the genetic counseling checklist and if or how this genetics training was used in practice. This was our experience. Every experience will be different and there'll be unique considerations for any location. Our hope is that by sharing our experience and some of the barriers that we encountered, future groups can have more anticipated barriers and fewer unanticipated ones. Along these lines, flexibility is extremely important. It is okay to deviate from your plan. An example of this was us changing the curriculum for cohort 2 to focus on the lessons identified as most relevant and most likely to be used. Part of the role of genetic counseling involves respecting clients' beliefs, circumstances, family relationships, and cultural traditions, and this aspect of the profession is especially important when implementing genetic counseling services or training for the first time in a country. For example, if and how facilitated decision-making and similar aspects of the North American view of genetic counseling are taught to providers will require discussions with providers to avoid conflict with established cultural norms. While we weren't able to achieve our exact goal of establishing a regularly utilized cohort of trained nurses who had the capacity to train additional groups, a number of important accomplishments were achieved that will further our group's efforts to introduce medical genetics in Ethiopia. Looking at all the work that was completed, these include identifying patient and provider interest in genetic counseling services, strengthening the relationship between our collaborating institutions, and establishing a cohort of nurses with training in genetics. For me, while the training was not exactly how we initially envisioned it, there are now over 20 nurses at St. Paul's with increased knowledge of genetic conditions and genetic counseling, and I consider that a win. Thank you to NSGC and the International SIG for inviting me to speak today, and another thanks to the entire team who worked to make this training successful.
Hi, everyone, and thank you, Grace, for helping me out today. Let me start off by saying thanks one more time to Grace for the kind introduction earlier and to my fellow presenters today. Your work inspires me to no end. I would also like to thank International SIG for the opportunity to present the important work done by the Pakistani Society of Medical Genetics in regards to genetic counseling training program in Pakistan. As Grace mentioned earlier, I am a full-time employee and stockholder of Natera, and this is my only financial disclosure. I'm also the co-director and founder of the Pakistani Society of Medical Genetics. Grace, if you could move the slide one more. Thank you. And one more, please. As Grace, I would also like to acknowledge my colleague, Myla Ashfaq. She is a genetic counselor in Houston and provided some of the slides that we're going to be looking at today. Before we dive deep into the state of genetic counseling in the country, let me take you on a quick virtual trip to Pakistan. From where we sit in the United States, for some of us at least, the country of Pakistan is all the way across. No, you can't see my cursor, but it's the little one in green in South Asia. You can go to the next slide. We'll zoom into South Asia, and you can see that the country is located in the subcontinent of South Asia, neighboring Afghanistan, Iran, India, and China. Just as a reference, Pakistan is not located in the Middle East, as some like to believe. As you can see from this map, Iran is the closest Middle Eastern country to Pakistan. The country is further divided into 4 provinces and territories, largely based on linguistic and cultural differences. The diversity is not only linguistic and cultural, but also landscapes are widely different from south to north and east to west. In the south is the province of Sindh, which is home to the ancient civilization of the Indus Valley. It is also the economic hub of the country, as the port city of Karachi is located in Sindh. In the west is the province of Balochistan that neighbors Iran and is home to beautiful deserts and beaches. In the east is the province of Punjab, the breadbasket of the country. Up north are the mountains, ranges, and valleys of the province of KPK and territories of Kashmir. The next one, please. This picture depicts the linguistic diversity of the country. While the official language of the country is Urdu, local languages and dialects are very different from one another. Folks that live only a few kilometers away would speak a different language or a different dialect altogether. With all the cultural and linguistic diversity in the country, the uniting factor among the population is the religion of Islam. 96% of the population are Muslim. When we talk about the healthcare system, it's largely out-of-pocket expense with some government-run hospitals that are subsidized. The top picture that you see there is one of the privately run hospitals called the Aga Khan Hospital. And the bottom picture is a charity-run hospital known as the Indus Hospital. An overwhelming majority of births, approximately 80%, are at-home births in rural areas with a high incidence of genetic disorders, with an estimated of 1 in 300 children born with inborn errors of metabolism, higher prevalence of autosomal recessive conditions, and 1 in 9 women are diagnosed with breast cancer, as compared to 1 in 13 women diagnosed with breast cancer in the United States. In addition to lack of awareness and public health infrastructure, one of the underlying causes of increased rates of autosomal recessive conditions is due to the relatively high rates of consanguinity in the country, where about 70% of marriages are between close biological relatives. The practice is not only culturally acceptable, but the preferred method of finding partners for a wide range of reasons, including strengthening of family ties, financial advantages for maintaining ownership of one's property within the family, adjustment period for women, or easier adjustment for women after marriage, and better relationship with their in-laws, a relative ease of finding suitable partner, as well as greater marriage stability and longevity. This increased incidence of hereditary conditions in the country is very well documented, as 2 recent publications showed a much higher diagnostic yield of genetic testing in the country as compared to the West. The medical community also recognizes this need for availability of genetic services in the country, as demonstrated by Myla and her colleagues, that presented a paper where 100% of physicians practicing in Karachi were in favor of referring appropriate patients for genetic counseling. At the moment, in the big city of Karachi, there are only 2 formally trained medical geneticists that practice in private hospitals, 2 genetic counselors that are under training of these 2 medical geneticists, and only a handful of in-house genetic tests that are cost prohibitive. Grace, if you can go, yeah. As you can see, testing for PKU, cystic fibrosis, Fragile X, karyotype, 22q11 deletion, Prader-Willi, and muscular dystrophy are amongst the very few tests that are locally available, yet they remain cost prohibitive. This discordance between the increased rate of hereditary and genetic disorders and the lack of genetic counseling workforce has created a need for a robust genetic counseling training program. However, any robust genetic counseling training program relies on infrastructure like universities that can offer the didactics, clinical rotations, and variety of subspecialties, local laboratories, as well as involved patient support groups. To fill these gaps, my colleagues and I established the Pakistani Society of Medical Genetics in 2020 with the aims of providing affordable genetic services in the country. If you could get to the next slide, thank you. And at the moment, PSMG is a nonprofit entity in California, and we are working on getting the 501c3 IRS status. And I want to give a shout out to my co-founding members there as well. As a first order of business, we conducted a needs assessment webinar where we invited panelists, including maternal fetal specialists, pediatric endocrinologists, laboratorians, medical geneticists, as well as patient advocates. In sum, the panelists describes a dire situation with a lack of genetics workforce, and I encourage you to look up the poster that we recently presented at the ACMG meeting for more details. As a result of the needs assessments webinar, if you could go to the next slide, please. So as a result of this needs assessment seminar, we were able to outline 4 main objectives for the society. Number 1 is provide clinical services. Number 2, laboratory services. Number 3, genetic education. And number 4, community outreach. As a first order of business, we established a relationship with government-funded clinics in Karachi and Lahore to establish telegenetics clinic. And the next slide will show those areas to you. So in Karachi, we have a pediatrics clinic at the National Institute of Child Health and a prenatal clinic at South City Hospital. While South City Hospital is a private entity, we only see patients that are financially restrained. And then at Lahore, we also established a pediatrics clinic at the Children's Hospital, Lahore. To establish those clinics, we hired a clinic coordinator at the originating site and trained them to take detailed pedigrees and medical history of the patients that were referred to the clinic. This information is then reviewed by genetic counselors, including myself, Ambreen Khan, and some other genetic counselors that work with us. And they also get to see these patients via Zoom. We create a plan for testing and management of the patients. These plans are then provided to the referring providers to help manage the patients. In just a few short months, we have seen a wide range of genetics and hereditary conditions, as you can see on the right side of the screen. The list is long and I have limited time. If you want to take a screenshot of these, more than welcome to, or email us later and I'll be happy to give more details. Next, we need to create a pipeline for genetic testing to be sent to outside laboratories in the United States or Europe or other parts of Asia. And we are working on establishing local molecular labs, which is proving to be a harder task with very limited funding at the moment. Next, we did some community outreach. We have taken up multiple fronts, including case conferences in collaboration with the Karachi Down Syndrome Program, as well as the educational posts that we post on social media, like platforms like Instagram and Facebook, in both English and in Urdu. With these building blocks in place, we feel that we're in good place to start a genetic counseling education program. For starters, we conducted a monthly online lecture series with topics ranging from introduction to medical genetics, genetic counseling principles and medical ethics, laboratory genomics, benign hematology, hereditary cancers, common genetic syndromes, dysmorphology, prenatal genetics, and inborn errors of metabolism. This year, we have conducted 3 case conferences in which we have discussed diagnosed as well as undiagnosed conditions. All of these webinars are recorded and are available at no charge at the website, and the web address is provided on this slide as well. Again, I couldn't move on from this slide without acknowledging each and every one of the individuals that took their time to participate in these online lecture series. And we wouldn't be where we are without their help and support. Next slide. So to establish a formal genetic counseling training program, we have also created a culturally sensitive curriculum by conducting a comparative analysis of the Western and Eastern genetic counseling curricula, as well as identifying the courses that can be taught by local professors and those that need to be taught by US genetic counselors. Since all science education in Pakistan is in English, we are definitely able to use our US and Canadian and European genetic counseling friends to assist with this endeavor. At this time, the curricula is under consideration for approval by the Dean of Local University and the Higher Education Commission of Pakistan. This massive endeavor would not be possible without the kind and generous donation of time and effort by my colleagues at the PSMG and all of our collaborators that helped put together the case conferences and lecture series. I encourage everyone looking to gain more experience in international genetic counseling to contact us, as we are always in need of volunteers. I'd also like to bring your attention to the plight of the flood victims in the country, and anything you can as an individual do to help with the relief efforts or the reduction of climate change would be much appreciated. Thank you for your time and attention, and I will take any questions that you have. Thank you.
Thank you very much to all of our speakers. I'll invite all three to join us live on the camera here now. We'll begin the Q&A session. So we have a little more than 10 minutes for our Q&A. So please put your questions in the chat. I can see that a few have already come in. So the first one is a question for Daniela. Brenna Bentley says, this sounds like a wonderful society. Does your group have resources for international students in LATAM who are interested in coming to the US for genetic counseling training programs?
Yeah, thank you, Brenna, for your question. We do not have any resources at the time, but I am aware that the International SIG does have some resources for individuals who are applying to school in the US and as international students. So I don't know, Grace, you can speak a little bit more about, I know that there's a document and sometimes there's also like mentorship opportunities for international students.
That is true. Definitely reach out to the International SIG to learn more about that. And we'd be happy to talk about all the different ways that we're trying to expand globally for our genetic counseling prospective students. Yeah. Okay. This next question is for Michelle, and it's from Smitha. Smitha says, thank you for your presentation. Could you speak to the importance of finding a champion physician or point person at the institute abroad? How can one try to find such a person at institutions we are interested in collaborating with?
That was very crucial for us. So I came into the work a little bit late. I think we were in a fortunate situation where our institution had an established relationship with the hospital in Ethiopia. And it was actually a lot of it being driven by the physicians that were located there to even get the project on the ground. Sorry, off the ground. But I think if you already have somewhere in mind, assuming they have, a website, just looking at people who maybe work in the area you work in and reaching out. I think if they're not interested, you can ask them to pass you on to someone who might be, but it was pretty crucial, especially trying to navigate at an institution where we didn't really have contact with many people outside of the physician champions, and where we wouldn't have been able to necessarily, or we wouldn't have been able to arrange logistics like recruiting the nurses, getting a conference room, etc.
Thank you. The next question is for Aisha. It's from Michelle Moore. She wonders, what was the hardest part to apply cultural competency to your program?
Hardest part to apply cultural competency. So the way we conducted this comparative analysis was that we looked at the curricula of 3 US-based genetic counseling training programs. If I can remember correctly, one was UC Irvine, one was Sarah Lawrence, and one was my alma mater, California State University, Stanislaus, and as well as Stanford. And then we looked at the curriculum from the Saudi Arabian genetic counseling training program. And when we were making the comparisons, some of the things that really stood out to us were those public health related courses that aren't really taught here, but were taught in Saudi Arabia. And we figured that would have a cultural part, as well as some of the medical ethics, including some of our laws against abortion and multiple marriages, because multiple marriages are allowed in the Islamic culture, Islamic religion. And we also had a few things that I can't think of at the moment. But this was a little bit challenging, because of course there were certain things that our US-based geneticists or genetic counselors wouldn't be able to teach, and only a local provider or local professor would be able to teach. And so we figured it would probably be best for some of these courses to be taught by local professors and providers, as opposed to some of our US-based providers. I hope that answered your question, Michelle. It was a little challenging.
Thanks, Aisha. It's a big question. Yeah. We have a practical question for Daniela. This is from Teresa Ray. Do you have materials in Portuguese for my Portuguese-speaking patients?
We don't have anything published at the time, but we are working on a visual aid for providers who speak Portuguese, so they can share with their patients some of the images that we typically share in our counseling sessions. So be on the lookout for that in the coming weeks.
Okay. So this looks like a question for Michelle and for Aisha. What have you thought about so far with regard to whether graduates of the training programs you've designed would be called genetic counselors or something else, and whether the medical system there would hire them to work as genetic counselors? And that was from Alyssa Terry.
I could take this one first. Yes?
Yes, please.
Okay. So a couple of things. The first thing, yes, these individuals would have a master's in science, and as such specialty would be genetic counseling. And that is our intent. And we also believe that with the gravitas that comes with the master's degree program, it will carry a weight. It is a degree that will be, knock on wood, approved by the Higher Education Commission. So it won't be just a piece of paper given by any university, but approved by Higher Education Commission. Secondly, I think this is such an important question, because we could not have started a genetic counseling program before making sure that these individuals will be employed and will be able to serve the community. And for that reason, our telehealth genetic clinics, our efforts in the support groups area, all of those are really important, as well as the laboratory setting, because without already having those in place, we wouldn't be able to have these individuals employed and pay off their student loan debt. I don't know how that all works in Pakistan, the financial system, I'm not too sure about, but whatever they're investing, they should be able to reap the benefits of it financially and gain financial independence. And so for those reasons, I thought it was very important for us to make sure that we create clinics where we can then employ these individuals and then continue the work that we have started, and it shouldn't stop with us.
And in our case, the purpose of the training was really to supplement the nurses' existing roles and skills. So they did all receive a certificate indicating they had completed the training program, but not intended to be sort of full functioning genetic counselors as we think of them, and not something where they would get an official degree. It was really like a certification from our program that they recognize within the hospital, but not anything that would be more broadly applicable. And just to go back to the other question, I do work with a doctor who's done work with in a few different countries, and he suggested if there are further questions about how to get started, that you email me and I'll put you in touch with him. So I will put my email in the chat now.
Thank you, Michelle. You know, as I listened to each of you speak, I was just struck by what huge endeavors these all were. I mean, it just seems daunting to look at the work done. So I was hoping you could tell us all how you stay motivated to do this big work that you're doing. Tell us what it takes to do a project like this.
I guess I can start. I think a big part of it is, having family members and people currently living in Latin America and these places, and acknowledging the fact that they don't have the same privileges that we do here in the US. And I think that's a huge motivator for myself, and I know a huge motivator for everyone else who works as a part of SPLAGen as well.
Michelle, if you want to take this one.
Sure. For me, I think just working with a really good team, so including the providers at my home institution, but also the institution we were working with, like everyone was very motivated to move things forward. And I think going into it for the sorts of trainings or situations I was in, going into it with the mindset of being flexible and adjusting things and realizing it's more trial and error than it needing to be perfect, I think took off some of the pressure that could have been associated with that.
Yeah, I would have to agree with both Michelle and Daniela. I think that that's one of the biggest thing. I also remember as a genetic counseling student applicant that part of my application included starting a society of Pakistani Society of Medical Genetics, and it took me 5-6 years to get that started after I had graduated. And so it was one of those itch that needed to be scratched. And on a very personal note, it and a very selfish note, it is very extremely satisfying to receive the feedback after you talk to a patient who has had no help for years, have a third child who has been undiagnosed all their lives and don't know the underlying reason, and just to provide them with a bit of counseling, not even anything fancy, and just be there and provide that unconditional positive regard that we're all taught to towards our patients is just the best. It's just so rewarding and it's so fulfilling. I would encourage everyone to do it just for selfish reasons, just for nothing else.
I think that's an absolutely perfect way to close today. So with that, just on behalf of the NSGC webinar subcommittee, thank you all for attending the webinar. Huge thank you to our speakers for sharing their stories and experiences. A reminder that this webinar recording will be posted to the webinar page of the NSGC website within 48 hours. Hope everyone has a great day. Thanks for coming.
Thank you. Bye-bye.
Bye.